And from different courses or from the Congress, the CRAFTA Congress we had this year. So I'm the first in line to give you some overview about one of the statements. In this case, it's the CRAFTA statement, headaches in children, which was stated in 2022, and you can find it on the CRAFTA website. And what we are talking about is a short overview about the important contents of this statement. I will talk a little bit about the introduction, about the classification of headache, sorry, about pathophysiology, additional factors like risk factors, and what can we as specialized physical therapists can do in the case of a pediatric headache. So when we look at the burden of disease research, then we see that in 1990, in children or in people between 10 and 24 years, we see that already then in the 90s, it was on third position of most burden for this group. But this changed in a few decades to the second place. So what we can say is that the burden of headache, and then the whole group of headaches, not a specific headache, but the whole group of headache among this age group is the second highest. So this is a major impact on the quality of living, on the life duration, and so on. So a lot of different things are connected to these numbers. So what is important? So some facts, because we have not so much time, but in the statement, there is Singhi is mentioned. So what has Singhi find out? That the headache prevalence in children is rising with age. So in the group of 3 years old, he found a smaller percentage than in the group of 8 to 15 years old. So that's in line with other evidence. What he also finds, together with also other authors, is that before the age of about 11, there is no difference between boys and girls. And after 11 or in the puberty, there are more girls, and then also until adolescence and adulthood, which complain about headaches. Yeah, you see here some other figures. You can read it in the statement because I cannot mention all the things. But one moment, it's not going well. So, but what's very interesting is also, and this was a study in the German children population, and a very big one, that there is also a difference between the mean age when the children get their headache, and also about the medical use of different medications and so on in different headaches and in different age groups. So this is also very important. And we see that migraine has a higher medical use than, for example, tension type headache or indefinite chronic headache. Yeah. And in the same study, we saw also that, and this can be confirmed with other studies, that the socioeconomic status has no relationship with headache, but a slight difference is in single-parent households. But when we jump to the last point on this slide, we see that there is a connection, a family connection with headaches. So when one parent has a headache, the children have a higher chance of getting a headache. And when both of the parents, we see also an increase in comparison to children where none of the parents has headache. Yes, so this is, I think, a very important point. And then we see that headache also can be connected to other chronic disease, and mainly these are also pain diseases. Yes, so we see that abdominal pain, back pain, especially in the group with very severe and also a very high frequent headache, has more other pain complaints, and especially in the back and in the abdomen, than children with less headache frequency and also without headache frequency. Yes? So the more frequency the headache attacks, the more other complaints in the body. And we have to be aware of it, because maybe we see the children in our clinic not because of the headache primary, but because of other complaints of the back or the neck or some other musculoskeletal regions. And then there arises the question, is there an increase in the incidence or in the prevalence of headache in children? And this is a very difficult question, because we cannot answer it straightly. So there is a slight increase. So there is a very big systematic review which could show a slight increase in the prevalence, also by increasing age. But we need more evidence to finally can give a good answer on these questions. Yeah. So the take-home message for this first part, introduction part, is what you have to remember is that the headache prevalence increases with age, that in adolescents, headache prevalence in girls is more often than in boys. And there seemed to be a slight increase in the prevalence in general for pediatric headache over the whole world. Yes? So according to the classification, the second one, so we already have the third one, and I will talk about it later. We have a lot of problems to classify the pediatric headache with the classification. Yeah, because the classification is mainly made for adults, and most of the research about headache is made in adults. So this is very difficult then to get good validated information for children. Yes, so these are the main take-home messages. Yes, so and then we have to talk about the classification, because this is up to today the only instrument we can, or not we, but you can get the type of headache, or doctors can diagnose the right type of headache and then start the proper treatment according to which type of headache it is. Yes, so in this classification, it's called the headache classification, the International Classification of Headache Disorders. We have already the third edition, which was from 2018. And there we have all the information and all the research about it. So it's a very huge document. If you want to, you can read it. But it has a lot of information about the typical features of the different headache types. But what for us is important, what is the difference, or what are the special points for children? What is the difference between the adult form of a special type of headache and in children? And when we look at the primary headaches, we know that there are some differences in some factors in migraine without aura. So, for example, the duration of the attacks, but also the location. So the pain is usually in adults, it's on one side, which can change in another attack, but usually unilateral. In children, it's more bilateral, and most of the times located more in the front of the head, and not in the occipital part. This would be very rare and should also call some flags because there is some diagnostic caution. So there are some differences where we already have enough evidence that it can be included in the classification. There seem to be no difference, or there is not enough evidence to show if there is difference in migraine with aura, in the tension type headache, and in other primary headache disorders. Yeah. So this is what the classification can give us as information, especially for children. And from external evidence, we know, for example, in migraine with aura, that aura symptoms are usually very rare in children, with exception of the visual disturbances. Yes, and other headaches than migraine and tension type headaches are also very uncommon in children. Regarding the primary headache types, which are consisting. And then there is a very good chapter about the episodic syndromes that may be associated with migraine. And this means that there are some special types of headache mentioned in the classification, which are mostly due to a certain age group in children. And you see them here. I cannot give you all the information about it. So if you want to learn more about it, you can read it in the classification, but be aware that it is something connected with the gastrointestinal disturbances. This can be cyclic vomiting syndrome, abdominal migraine, so where the children don't have the headache, but have the same signs and symptoms like they have headache, but they have it in other parts of the body. We have the paroxysmal vertigo and the torticollis, which are these 4 different types. And in the appendix, we have some additional pediatric headaches, which are very rare, but there is enough evidence that in the classification is enough room for them to present. This is the infantile colic, the alternating hemiplegia of childhood, and the vestibular migraine. So in some cases, maybe you will have a child in your clinic with one of these special syndromes. And then it's important that you recognize, hey, this could be one of these special syndromes and what is known about it. And here you see an overview about the first 18 years, when typically is the age or the time when the different types of pediatric headache occur. Yeah, so then you know already a little bit, is this 15-year-old child, okay, the chance is very small that you have one of these groups, but maybe abdominal migraine or one of the standard primary headaches. Yeah, so this is a good overview where you can judge this already. And what about secondary or other headaches, which are also mentioned in the classification? So there is little known about it because we don't know enough about the incidence in children, because there are nearly no good research about it. What we know is most frequently is viral infects, and then particularly the respiratory tract infects or headache due to minor head trauma. Yeah, so this is something which occurs more often. This can lead to headache, must not lead, but can lead to headache, and this is interesting, and later on we will talk about these minor head traumas also. So the take-home message about the classification I will give you today is that there are differences, some small difference already mentioned now in the 3rd edition of the classification, but we are still, and jump to the last point, we are not satisfied with it because it's still not possible to classify all the children with different types of headaches with the classification. So there is still a lot of critique about this. Yes, and there are the special migraines we already mentioned. The tension type headache classification seems to be the same in children and in adults, and the other headache types are uncommon in children. Yes. So what is then the pathophysiology behind headache? So this is a very interesting question. Some things are known, not all of them. So there are some theories. And one of them is that there is an influence of the epigenetics. So this means, short described, that a lot of genes are already detected, which can be turned on or off through different situations in life, which we not all know, and they can then have an influence how our system works. And it's estimated that the genetic factor in this pain problem is about 60 to 70%. And some additional environmental factors can also be of interest. And then when you divide the pathophysiology, at the moment there are two theories which go a little bit also hand in hand. So the first is a vasogenic theory. And this is a theory, there is involvement of the function of the extracranial and intercranial blood vessels, and they can be disturbed, and therefore there can be a pain problem. And the other one, the other theory is the neurovascular theory. And here we have some different innovations, like the release of nociceptive substances in the brain, and then the stimulation of C fibers. And we have also involvement of the trigeminovascular fibers, which surround these blood vessels, mainly then intercranial blood vessels. And to make it short, what is very important is that there seems to be an involvement of the cerebral cortex in this pain cycle of mechanism, and there seems to be an involvement of the trigeminovascular system. Yes, and there is good evidence for these two involvements, for these two theories. So, for example, for the trigeminovascular system, there can be some input from the trigeminal ganglion, and this input can be due to some irritation on the meningeal vessels, on the meninge itself, on some parts of the face, which are innervated through the trigeminal nerve. And this can be projected in the trigeminal nucleus of the brainstem. And then we have these signals further up to different nuclei in the thalamus, and then it goes to the somatosensory cortex. But also some different innervations of or stimulation of the blood vessels, which was also one of the theories. And this could be then give the special pain in the different headache groups. Yes, so to make it short, there is some involvement of these different pathways from the face, from the neck, and from the head, which is all connected to the trigeminal nucleus in the brainstem. So the take-home message for the pathophysiology, and I know it was very short and very short overview, but if you remember, the pathophysiology is still not clear. So there has to be more research on it. And migraine and tension type headache in children seem to have similar pathologies as in adults. So There is no difference at the moment between adults and children because there is no sufficient research on it. But epigenetic mechanisms are already detected, so that there are different genes which can, in a different on or off stand, be involved in the pain provocation. And the cerebral vessels seem to play also a certain role, and together with function of the cerebral cortex and the trigeminovascular system. Yes? So now we have to talk about additional factors. And additional factors can be risk factors, like female gender, like stress, like sleep problems, like fatigue, like dizziness, but also like familial headaches. We talked about it. If one or both parents has already headache, then social emotional stress, and this is also very important for us physical therapists, a low cervical range of motion, and also a high cervical movement limitation. So this is all according to evidence. We know already that these are risk factors to get a pediatric headache. Yeah, and they are similar to the risk factors of adults. Yes, and then we have another group of additional factors which are called comorbidities. And you see here some of them where there is strong, moderate to strong evidence about that they often go together with headache. So this is not the reason or the cause of headache, but they go together and can influence each other much more often than in children without headache. So, and what's most interesting for us as physical therapists are the last three, I think, is the obesity, the musculoskeletal dysfunction, and the vestibular dysfunction. And when we zoom in about the obesity, then we know that there is an increase in obese children in nearly all the age groups. We have here very recent research that shows that between 1975 and 2016, the obesity in girls is gone from 0.7 to 5.6, and in boys from 0.9 to 7.8. So that's very, very severe. So obese is one thing we have to deal, not just for headache problems or complaints, but also for a lot of other medical and health issues. Yes, and then we have the TMD, the temporal mandibular dysfunction. And this is a lot of text. What is here? You can read it in the statement. But to sum it up, it's important because the TMD, you remember that the trigeminal influence on these problems can have an influence on how these pain pathways go to the brainstem, to the thalamus, and then to the somatosensory cortex. And there seemed to be a connection between problems in the temporomandibular region and headache. Yes, and what we also have to know is that the occlusion can have influence on this connection between TMD and headache, and then especially overbite, overjet, posterior crossbite. So especially the crossbite, when it's not corrected, can have a lot of influence. So when there are two or more of these occlusal factors, there can be a higher risk of headache. So this is very interesting because this is one of our main specialties in the CRAFTA therapy. Yes. So, and then we have the cervical region. And the cervical region is often limited in the active movement. Yes. So neck pain is associated with migraine more than with tension type headache. And in the chronic tension headache, we see that the movement is decreased. Yes, and also the craniovertebral angle is different. Yes, so also the posture can change and can be tested. We will talk about it later. For example, with the flexion rotation test, it's also very good validated in children. Yes, and then there we have it, the traumas. So traumas, we can differ between the mild traumatic brain injury and the normal brain injury. And there seems to be, especially in girls, there seem to be a connection between the mild traumatic brain injury and headache. Yes, and it's not the same when we have an arm injury, for example. So a bump or a trauma to the head or the neck can make the incidence of headache higher, and that's most of the times not immediately after the trauma, but after a few weeks or months. And most of the times it's gone with a year, but in some cases there is report that it's still severe, and then most of the times very severe. And we have to be aware that there can be a connection between the headache and vestibular problems. And you can call this migraine-related vertigo because we have some special pediatric headache I mentioned before, which can have a lot of vestibular symptoms. Yes. And there is a kind of vestibular migraine also exists. And here you can see that there are different types of vestibular disturbances. And not all of the children, it's a small group, but some of the headache children, and then especially in the migraine group, can have also these vestibular problems. And most of the times it's not a peripheral vestibular problem, but it's a central problem due to maybe the same mechanism which caused the headache in the first place. Yes. So what can a specialized physical therapy do in children with headache? Yes. So according to the clinical reasoning model, we have our plan with first starting the subjective examination. And if we decide to go further, there are no red flags, for example, additional questionnaires can be possible, and then the physical examination. There is already a lot research about the red flags in children. So we have to be aware of it, and we have to check in the subjective examination. Besides that, we check if the signs and symptoms are according one of the types of headaches mentioned in the classification. If there is one or more red flags or some other points where we don't know exactly if what it means. So then we have to refer to a physician or to a specialist. Yes, but if we don't find any red flags, and it seems to be one of these headache types, we have then the possibility to use some questionnaires about different factors related to the headache. But the most of the questionnaires you mentioned here are not especially for children and are not available in different languages. So it is very difficult to find a good questionnaire for the subjective examination in children with headache. Yes. More important is then the physical examination, the inspection and observation. Think about the spine, especially the cervical spine. We already talked about which changes we can suspect, but also the general posture and the head posture. If the children are smaller, look at the symmetry or asymmetry of the head and maybe even the face. Think about some other problems here in the growth of the cranium, the muscle tone of different muscles in the head, but also the proportions, then the skin. So do we see some special features like color, scars, swelling, bruises, the facial expression on pain, but also on other expressions, and the body extremities and head movements. So this is everything we can look already when we look at a child. And then we can add, if necessary, the palpation. Yes, this is also one of our main skills. To look for anatomical orientation, to identify tissue changes, abnormalities, and to make our reassessment after a while. Yes? And then we have the typical clinical testing, like general conditions. We can check here, for example, the head circumference in the different age groups, according to the World Health Organization, but also the motor function according to the age. You see here some of the tests which can be possible for these different age groups. But also then check the jaw if there are signs and symptoms already mentioned in the subjective examination. Look how is the active jaw movement, especially in the depression of the mouth, but also in other directions, and how is the quality. And then maybe you want to check the palpation of the jaw muscles. You can do this just with your fingers, and then mainly on the temporal and masseter muscle. But also you can use, as in this example, the algometer to check very exactly when is the pressure pain threshold, for example, and compare it to the other side or after the treatment and so on. But also think about our special possibilities to check the joint, the temporomandibular joint itself. If there is some noise, you can do a registration testing with the stethoscope. But to my experience in children, we don't find crepitation or clicking, not so often as in adults. And then we have the cervical and upper cervical region. If there are complaints, then we check first the active movement. You see here a table of the possible cervical movements from controls without headache, and then you know if it's limited or not. But also maybe the passive movements, especially for the upper cervical region, are very interesting. Because there can also be problems locally, but also then referring to the head, which would be then the so-called cervicogenic headache group, and this falls into the secondary headaches. And if the upper cervical region is limited in movement, we can do the flexion rotation test. And you see here that in children, we can suspect a rotation to each side about 50-52 degrees. And in children with cervicogenic headache, it's decreased on the side of the symptoms of the headache. Yes, so also on the other side, but mainly on the side of the symptoms. So this gives us a very good information about local problems which can be of influence on the headache. And then, if necessary, we can check the vestibular system. We can do some standard equilibrium tests according to the age group. And we can do the modified Dick-Halpig maneuver, which can a little irritate the vestibular pathways. And then we can look if they also can trigger the headache. And then we know maybe there is a connection in it. And we have to implement it in our therapy. Think also about the nervous system. When there are neurological signs, you have to screen them if it's necessary, especially when there is involvement of cranial nerves, which we have to test. But mainly think in children with headache on the neurodynamic testing of the whole peripheral nerve system. And then you can see, because we know already from one study from Harry from 2007, that in different primary headache groups, in primary and secondary headache, because migraine, cervicogenic, and control, we have different responses in the body during the long sitting slump. Yes, and you see here the differences. And to sum it up, we can say that different pathophysiological mechanisms for the two different headaches can lead to different biomechanical patterns of the craniocervical region. Yeah, and the whole neurodynamic nerve system can adapt on it. And we have this information. We can use it for our treatment and for our reassessment. And when we talk about treatment, then usually the pain treatment of the primer pain treatment of a headache, pediatric headache, is the pharmacologic treatment. And there you have also different branches of treatment. I don't want to jump in on the pharmacologic treatment. I will mention the non-pharmacologic treatment, and then especially the behavioral treatment and some other. You see all of these treatments which are mentioned here at the non-pharmacological side has minor to moderate evidence. And then we have the treatment of the comorbidities, maybe also the risk factors, but some of the risk factors we cannot treat because they are given facts. Yes, so but when we come to non-pharmacological treatment, we have the behavioral treatment, treatment adherence. In children, it's sometimes easier to get the adherence than in adults because we can integrate plays and different kinds of motivations. We have the lifestyle management and we have the psychological interventions. In lifestyle management, think of all the like sleeping, like diets, like drinking patterns, and so on. And in psychological interventions, think about relaxation techniques, biofeedback, virtual reality, and so on. So there is already some evidence that these non-pharmacological treatments can be of influence in headache. Most of the times, the best influence is when it's combined with the pharmacological treatment. Yes? Then think about training, and then especially endurance training, which can be important for children with obesity, but also with some motor problem or equilibrium or vestibular problem, but also general condition and other body systems can be positive affected throughout training, and pain education. So there are some concepts of pain education which are already tailored for children. The last years, there is some good concepts already published and available for physical therapists. So if you know them, use them. This is very important and can have a good effect on the treatment outcome. And then when we again look at the comorbidities, we have not only the opportunity to have an influence with the physical therapy on obesity, musculoskeletal dysfunction, and vestibular dysfunction, but also on the atopic disorders, maybe on psycho-emotional disorders, and maybe on sleep disorders. Maybe indirectly we have some influence on it, and it depends on our knowledge and our possibilities. And then think about the treatment of the special musculoskeletal dysfunctions. So it depends on what you find in the subjective and physical assessment, and then you can act on it. So it will always be an individualized treatment plan. But we can influence the motor and movement skills with exercises. We can influence the functions of the TMD. We can mobilize. We can practice active movement. We can change the way the muscles function and so on. Think about the cervical region. Also, we can change the active, the passive movement. We can change the muscle, we can change the postural control, and so on. But also, and I didn't mention it in the physical examination, but think of the craniofacial region. If there are problems with asymmetry, with growing problems, with inflammatory processes, we can also look if they have influence on the type of headache or are the cause of maybe a secondary headache. And then the nervous system, which can be influenced if the testing is positive with different concepts. And if necessary, we have also possibilities to train the vestibular system and to train the oculomotor system. Yes, so if it's related to musculoskeletal problems. And then I would prefer also to use some new treatment options like the mirror therapy or like laterality or emotion recognition training, which is online possible. Of the My Face training website, you can see further information about it to integrate it in the treatment of different problems, not just headache problems, but different problems of pain problems in the head, jaw, and neck area. And all of this is due to the general treatment goals. Yes, so you think, okay, the pain has to be less and less often, but the AAN, the American Academy of Neurology Practice Parameter, has some treatment goals mentioned in their in their research. And you see the 6 points here. You can read them in the statement on the CRAFTA website. And you should look if you can fill in some of these treatment goals according to the signs and symptoms and complaints of the individual child, if you can reach these goals. And then most of the times we work interdisciplinary with this pain treatment in children with headaches. So it's very good to have good connections with doctors, specialists, with speech therapists, with all kinds of other disciplines which are of interest in treating these children with the different headache groups. So the interdisciplinary is very important in treating these children, because if you saw at the comorbidities, for example, a lot of these problems we cannot solve alone as a physical therapist. So the take-home message would be that for treatment, the pharmacological treatment is proven effective but has side effects. So we have to mention this, and also to the patient and maybe to the parents of the patient. What is also very interesting is that the placebo effect in children seems to be higher than in adults. So we can work with it. It's okay to work with placebo effect in a positive way. Then the non-pharmacological treatment I just mentioned. So if you have any knowledge and skills about, use them, like pain education, maybe behavioral treatment, and combine them together with local hands-on techniques and exercise, for example, yes, due to the individual child. Yes, so this would be the important take-home message about the specialized physical therapy. And if you want to find out more about this statement or about other statements or other informations, you look on the CRAFTA.org website and you will find it. And the information for this special statement is also within the topics of the special course, and you can find it there too. Yes. So, and then I finish my excursion of the statement of headache in children, and will give the word shortly to Harry to introduce some new courses.
Okay, thank you very much, Danielle. We have time left for questions. Don't hesitate about it. Yes, I want to emphasize because there were some questions about this from certificate CRAFTA colleagues. We have an update CRAFTA courses in Holland, that is in Dutch and in English. Yeah, that is in March and May and October in German. Yeah, in Hamburg and in Vienna. Yeah, so this is special important for the people who did the courses before 2021. Because we have now a little bit another structure. We have embedded a lot of new knowledge, and because there's a lot of paradigm changes also. So if you did a course in 2007, yeah, it has to be a must to do this course. Yeah, that's I think very important. And then the next one is there was also a question from Ingeborg. There's a new course that is called Orofacial Somatosensory Distortion. This is working where we all work about 14 years on these things. We have now structured it, and there's a special website also. You can look to it on www.myfacetraining.com. And we have an introduction course that is an online course where you get also the package from the My Face Training courses. Yeah, and you can, this is the first experience with it because it's a very systematical training. And the second one is an online course from 3.5 hours. And the first is an introduction that is covered by videos and questionnaires and so you can work with it the whole day long. Yeah, and then we have a 3-day attendance course, 3 days. Yeah, in May in Hamburg and in Klippenfeld, that's in the south of Germany, where we do 3 days. Yeah, and this goes on not only on pain or facial pain, but also on neurological patients like facial paresis, Parkinson patients, patients after concussions, and so on. Yeah, so this is also accredited for CRAFTA points. Yeah, and yeah, so there's only I want to say that because to be informed that you are informed. Then, Danielle, there is a question from, I thought, Gabriella Proas. She asked,
One moment, I will stop now.